Hello everyone. Today we will be reviewing how to perform an awake bronchoscopic intubation. Over the next 5 minutes we will cover the indications, procedural steps, and a few common pitfalls associated with bronchoscopic intubation. An awake bronchoscopic intubation should be the technique of choice when managing a known or anticipated high-risk airway. For the anatomically challenging airway, such as the patient with cervical spine instability, restricted mouth opening, or tumor obscuring upper airway structures, the bronchoscope allows for direction visualization through the vocal cords and into the trachea. The high-risk physiologic airway may be more difficult to identify, but equally important to consider. An awake approach with adequate topical anesthesia prevents the need for sedatives and paralytics, which helps to limit hypotension. Patients are able to be oxygenated and ventilated spontaneously with support from high-flow cannulas or nasal BiPAP throughout the entire process, which limits hypoxemia and acidosis. Utilizing an upright position also reduces aspiration risk and helps maintain functional reserve capacity, which can be reduced by up to 30% in a supine position. Despite being considered the gold standard approach by the Difficult Airway Society of the UK, this technique remains underutilized. Patients must be able to follow basic instructions and cooperate with the administration of topical anesthesia. Adequate numbing of the soft palate and posterior oropharynx can take time, which may not be available in the acute setting. All necessary equipment must be readily accessible and familiar to the airway team. While the technique is simple, training and experience are critical to success. The necessary equipment for awake intubation include the Williams airway. A 10 cm airway is preferred as it will accommodate a 7.5 or 8 endotracheal tube. An atomizer and 10 cc syringe. 5% lidocaine ointment. 4% lidocaine solution. 1% lidocaine solution lubricant spray and an endotracheal tube. The patient should be positioned upright in bed to preserve optimal lung volumes and respiratory mechanics. This also reduces regurgitation and airway crowding. Minimal sedation should be administered to ensure patient cooperation and avoid apnea. Small doses of benzodiazepines and fentanyl may be used judiciously. The bronchoscope monitor should be set up to permit the intubating physician to maintain a constant view of the airway structures. Administering sufficient topical anesthetic is crucial to achieve a successful intubation. This process requires a knowledge of the upper airway anatomy, a willing, cooperative patient, and time. There are 3 neural pathways that supply sensation to the airway structure and are involved in brainstem-mediated reflex arcs. Terminal branches of the trigeminal nerve, cranial nerve 5, supply the nasal cavity and turbinates. The glossopharyngeal nerve, cranial nerve 9, supplies sensory innervation to the oropharynx and posterior third of the tongue. Chemical and mechanical stimulation of the glossopharyngeal nerve trigger the gag reflex. The vagus nerve, cranial nerve 10, innervates glottic and subglottic structures. Its branches, including the superior laryngeal nerve, play a role in the glottic closure and cough reflexes. Topical lidocaine is used to anesthetize these nerves. Proper administration may take up to 10 minutes. Lidocaine has an onset of action of about 3 minutes when applied to the oral mucosa, and its effect lasts for about 30 minutes. Now we will demonstrate each step of an awake bronchoscopic intubation. First, 5 ml of 4% lidocaine is drawn into a syringe. Half of this lidocaine is applied to the posterior oropharynx through the atomizer in a sweeping motion. This targets the tonsillar pillars and glottis. The patient should be warned that coughing is expected. The distal end of the Williams airway is then coated in 5% lidocaine ointment. The airway is slowly advanced into the patient's mouth. If the patient coughs or gags on the airway, the device should be retracted slightly before continuing to advance. This requires patience and additional ointment may be necessary. The remaining 4% lidocaine solution is then sprayed over the structures of the posterior oropharynx with the atomizer in a sweeping motion. Once the airway is in place, the endotracheal tube is sprayed with lubricant to ensure smooth passage through the device. The endotracheal tube can then be partially inserted through the Williams airway as shown here. The curve of the Williams airway allows the distal end of the tube to sit just above the larynx. With the endotracheal tube primed and in position, the bronchoscope is advanced through the tube until the vocal cords are in view. 2 to 3 milliliters of 1% lidocaine is instilled through the working channel of the scope to further anesthetize the cords. The bronchoscope is then driven to the main carina and held in place as the endotracheal tube is advanced through the cords and into the trachea. Appropriate tube depth is confirmed with the bronchoscope before the scope is removed. With the endotracheal tube in position, the cuff is inflated and a bag resuscitator is connected so that breaths can be assisted before proceeding further. To remove the Williams airway, the endotracheal tube adapter must be separated from the end of the tube. It is helpful to remove the adapter while keeping it attached to the bag resuscitator so that the piece is easily accessible and not misplaced. Some force may be needed to remove the adapter, so it is important to manually secure the endotracheal tube while performing this maneuver. The Williams airway is then removed from the mouth while applying a gentle opposing force to the distal end of the endotracheal tube. The bag and adapter are reconnected to the tube and breaths are delivered. The endotracheal tube can then be fully secured and the patient can be connected to a mechanical ventilator. One troublesome pitfall occurs when the endotracheal tube is impeded by the arytenoid cartilage and cannot be advanced through the vocal cords. This can usually be remedied by applying a counterclockwise twist to the endotracheal tube with gentle forward pressure. This will help slide the tube off the arytenoid and over the bronchoscope into the trachea. Additionally, it is helpful to use a bronchoscope that is similar in size to the inner diameter of the endotracheal tube. By limiting the gap between the scope and the tube, there is less chance of snagging on the arytenoid. We recommend using a standard bronchoscope paired with a 7.5 endotracheal tube. If an ATO or larger endotracheal tube is required, consider using a therapeutic scope for the procedure. As we reviewed, this procedure takes time to be performed well, and patient conditions such as changes in hemodynamics or an inability to cooperate may force providers to abandon the approach. A plan B is always recommended, and medication for a rapid sequence intubation should be on hand. In summary, the awake bronchoscopic intubation technique is ideal for the high-risk anatomic and physiologic airway. It helps to limit hypoxemia, hypotension, and acidosis, which can be deadly for the potentially unstable patient. Successful intubation using these steps is reliant upon a clear plan, a cooperative patient, an experienced practitioner, and plenty of topical anesthesia.